Thank you very much, Jennifer, and good morning, everyone and friends. It's a privilege and a pleasure to be invited to do this keynote address, as it has been a privilege and a pleasure to meet with and converse with so many of you individually during these last 2 or 3 days. So thank you again for this fantastic opportunity and for what has been another excellent Congress following on very successfully from Barcelona 2 years ago. So I want to take you through the journey towards a conclusion that rather paradoxically I want to begin with. So I want you to go home with this message, which is a positive one, and we've had some smiles on our faces during the days, and in the last half hour. But I hope to take you away in your journey home with a smile also still on your faces, because the conclusion that I'm going to present you with at the end of this half hour is that there are positive results from randomized controlled trials of individualized homeopathic treatment that are potentially crucial in defending and promoting homeopathy as a clinically effective therapy. So we'll take us through that over the next 28 or 29 minutes. As Jennifer has emphasized, my emphasis is on randomized controlled trials, which are at the top of the World Health Organization's hierarchy of evidence, clinical evidence. Category 1 evidence, the reason that randomized controlled trials are crucial and at the top of conventional hierarchies is that it is the only method that enables a clear inference about the cause and the effect of an intervention. There is no other that does that in any similar way. So we have to connect with it, and we have to get it right methodologically for homeopathy and for mainstream science and medicine. So this work is a systematic review of randomized controlled trials in homeopathy. It provides a qualitative overview of the evidence. That's what a systematic review is. And that systematic review can be, in general terms, one for a given medical condition, for a given homeopathic medicine or mode of homeopathy, or for all homeopathic interventions put together, as in some cases that you know in the literature. A meta-analysis, which can be an extension of a systematic review, and is the case in this presentation, provides a quantitative estimate of homeopathy's treatment effect size in a given category, such as those in the 4 instances above. And the reason that one thinks importantly about meta-analysis is that with more than one RCT, we increase the total sample size across the given area, and we therefore increase the statistical power to detect a difference between homeopathy and whatever, if one exists. I want to take you briefly through an example of a meta-analysis so that you have the mindset to go into the rest of the presentation, drawing an example from a Cochrane review in Oslo Cocainum that Peter Fisher and Joyce Fry and myself published 2 or 3 years ago now. So the essence of a meta-analysis is that individual trials represented here by the Fairley and the PAP trials that many of you will know individually, you have a treatment effect on an odds ratio that neither is statistically significant. Statistically significant would be the case when the line of no effect has got no interaction with the 95% confidence intervals of the 2 trials. So here we have the mean and the 95% confidence interval of each of the trials. Neither is individually significant. But this particular example at the 3 days after intervention, the pooled effect of the 2 trials together is statistically significant. Neither end of the lower end of the 95% confidence interval does not pass the line of no effect. So that is a statistically significant result based on a meta-analysis. I'm suffering a little bit from heavy talking last night at the at the party, and I think I'm not alone. Okay, so importantly, what are other reviewers' conclusions about homeopathy and placebo? Lind, our friend Lind, his conclusion was that the results of his meta-analysis of randomized controlled trials are not compatible with the hypothesis that the clinical effects of homeopathy are completely due to placebo. Many of us in this audience, including myself, will have used that phrase many times over the last 18 years. Our not-so-friendly Shang, finding from his meta-analysis that homeopathy is that his results rather are compatible with the notion that the clinical effects of homeopathy are placebo effects. And sadly, many of us had to quote that statement too. In the UK, in the United Kingdom, the Parliamentary Science and Technology Committee 5 years ago, which both Peter and I and others contributed unsuccessfully to, concluded in their report that homeopathic products perform no better than placebos. Now, I want to address importantly the matter of medical conditions. What are other reviewers' conclusions about medical conditions with respect to the homeopathic interventions? Lind, in his conclusion, was that there is insufficient evidence that homeopathy is clearly efficacious for any single clinical condition. That was 18 years ago. Not many months ago, in fact 2 months ago, the Australian NHMRC report concluded, with different criteria and a degree of stringency that we might rightly be upset by, there are no health conditions for which there is reliable RCT evidence that homeopathy is effective. Now this is a concern. The placebo matter is a concern, but we've got some positive to build on and for the work that I'm presenting today. The medical condition problem may be more enduring, because although these studies that I've cited with negative results of any given medical condition or non-conclusive results from any given medical condition are concerned, I know from my own analysis that with the small numbers of RCTs in any given medical condition and the small treatment effect size that sometimes manifest, it's going to be a hard ask to get positive findings across a range of clinical trials in any given medical condition. So I think we have to address this with some care and concern. So I want to present the findings from my overarching review of medical conditions that you'll find on both the BHA and the Faculty of Homeopathy websites. So there are 36 peer-reviewed reviews of homeopathy-focused systematic reviews. As you'll know from those websites, 44% of them are positive. But in the last month leading up to Rome, I thought I'll have a look to see which of those 16 of 36 have unambiguous positive statements about conclusion. One of only 3 is Jennifer's study on childhood diarrhea and the associated meta-analysis. No important caveats in that study. Results fairly unequivocal. However, the other 13 have got really important caveats. There are actually only 3 strongly positive systematic reviews, with or without meta-analysis, on specific medical conditions. 25% are non-conclusive, and a third or so have got negative conclusions, in which the majority have no important caveats whatsoever. So that's a balanced, I hope you accept that this is a balanced scientific review of the genuine peer-reviewed systematic review literature. So it's not sufficient. Why is it not sufficient? I've already stated it, but more specifically, most systematic reviews and/or meta-analyses have not adequately explored study quality, risk of bias, i.e. internal validity. What is reliable evidence? What is the size of the treatment effect, which might in some cases be small, and even additively across a small number of studies may not be statistically or even clinically significant? We need to distinguish the peer-reviewed from the non-peer-reviewed literature up front, which we have been doing. It's absolutely critical to reflect the very significant difference between individualized and non-individualized homeopathy. And the fact that, as you'll know from some of our recent initiatives, the model validity, which is the quality of the homeopathic intervention and its associated outcome measure and measured endpoint, is absolutely vital, because if we have on the one hand risk of bias assessment, then it could be a trial in which the homeopathy delivered to the patients wasn't up to scratch. So it's that we assess in model validity. And the difference between treatment and prophylaxis. Very few systematic reviews have distinguished those. It's amazing. And this whole thing about medical conditions. At this stage, it's really critical for me to acknowledge the enormous contribution of all and each of my research collaborators, without even one of whom this work would have either been extremely difficult or actually impossible. So I want you to have this in mind, and it's also in the abstract in your program, so you can have it in front of you through the rest of this session. The hypothesis for this work is that for the spectrum of medical conditions that have been researched using the relevant randomized controlled trials, the main clinical outcome of individually prescribed homeopathic medicines is distinguishable from that of corresponding placebos. So I'll just leave that for a moment, because I want you to think about what that means in all its detail. We're talking about individualized prescriptions and the prospect that those can be distinguished from placebos delivered in the situation of individualized treatment in a placebo-controlled trial. So another way of saying this is, do individually prescribed homeopathic medicines have specific treatment effects? And the work is published. The risk of bias internal validity work is published. It's in Systematic Reviews, December 2014. I'm sure many of you will know this study, this paper. And very briefly, within the time available, I'll just run through this in a second or two. 7 domains of assessment of risk of bias are all Cochrane standards of randomization, allocation, concealment, aspects of blinding, completeness of outcome data, selection and bias in reporting outcomes, and whether there's, for example, an unbiased baseline between groups. Again, time cannot possibly permit me to tell you how we came to 32 studies that were eligible, but it's all in the paper. 32 studies were eligible in the context of individualized homeopathic treatment, placebo-controlled, across 24 different medical conditions, within which there were 28 different main outcome measures that we attributed for reasons, again, that I could but won't articulate just now, with measured endpoints that for any given trial were anything between 12 hours in an acute study and 12 months in the case of an extreme chronic study, randomized controlled trial. For reasons, again, that I'll tell you about over coffee and so on, and it's in the paper, 22 of the RCTs only out of the 32 had data that were extractable for meta-analysis. And the findings from the risk of bias are that, rather regrettably, 10 of them, nearly half of them, had high risk of bias in at least one of the 7 Cochrane domains, making it at high risk of bias overall. 12 of them had uncertain risk of bias, and really rather disconcertingly, none had no risk of bias whatsoever. As I'll come back, there's more smiles can come back in the faces in due course. This is, I would say, the low point in the smile factor. So here's the meta-analysis. This is a slightly different presentational style from the example from the Cochrane review I cited 10 minutes ago. But here we've got the same whole thing about the line of no effect, individual trials with the mean and 95% confidence interval in each case, and the pooled treatment effect across all 22 studies. It's very faint, I'm afraid. For those in you at the back, homeopathy favouring on this side and results favouring placebo on the left. So you can see at a glance that the majority of studies are disposed towards homeopathy. But what you'll also see is that most of the single studies do not each in themselves have a statistically significant effect towards homeopathy. There are only 2 or 3, I think 3 actually, in which is an example here, in which the specific study had in itself a positive finding. Collectively, they do. And the interesting subset analysis is that those with unclear risk of bias have actually got a significant treatment effect pooled, and those with high risk of bias do not. They're not statistically significant, the ones with high risk of bias. So what is reliable evidence? This is our own terminology because none exists in the literature. It's quite extraordinary. So we attribute reliable evidence in randomized controlled trials as those that are free of bias in at least 5 of the, we'll talk about blinding in an overarching way, at least 5 domains of assessment, which must include randomization, allocation, concealment, and blinding. Trial absolutely had to it was required to be at low risk of bias in those attributes. We allowed one of the remaining domains to be of merely uncertain risk of bias. As soon as anything became at high risk of bias, then it had overall high risk of bias. But a reliable trial is one with those attributes adhered to. So doing a sensitivity analysis, as it's called, where you kick out all the poor studies and you retain the best, and in this case what we call, reasonably I think and I hope, reliable evidence, you can see that collectively we retain the statistically significant treatment effect across the 3 studies, despite the fact that only one of them individually has a positive findings. You can see also as a corollary that if it weren't for our chair this morning and for Iris Bell, the homeopathic community would be seriously depleted in research. So thank you, Jennifer. So to summarize this part of the talk, 22 RCTs were collectively positive with a mean odds ratio of about 1.5. The 3 randomized controlled trials with reliable evidence were also collectively positive at an odds ratio of around about 2. It means that quality doesn't seem to have an impact on a significant impact on the degree of treatment effect, which is a really important finding. And saying it in statistical terms, we have a statistically positive result across all 22 studies that's robust to sensitivity analysis based on reliable evidence. Other way of saying it, again statistically, but words that you might like in what your own vocabulary, is compared with those randomized to placebo, the trial participants randomized to individualized homeopathy were up to twice as likely to have a positive clinical outcome from treatment. That's what an odds ratio of 2 means. It's a case of being twice as likely. So the overarching conclusions from this phase, our data are consistent with a small clinical effect due specifically to the medicines prescribed in individualized homeopathic treatment. Now, no one has been able to articulate that statement before. Caveats nearly always exist in science. It would be rather surprising and worrying if they didn't. So the caveats to this are, as you've sensed already, the overall quality is not as high as we would prefer. The high quality trials do exist. And if I had been able to say to the Science and Technology Committee 5 years ago that I can name you and will name you now 3 reliable trials collectively for which has positive studies, conclusions, we may have had a different report, although that committee's bias might have predisposed. So we have an unclear overall risk of bias that therefore we can't pin this to, really decisively. Okay, so next phase, model validity. We have that defined, and that's not our own definition, we've just got slightly different vocabulary from some others, is the extent to which a homeopathic intervention and the main measure of its outcome, as implemented in an RCT, reflect best clinical practice in homeopathy. There are 6 domains. This work was published in BMC Methods and, yes, thank you, Kate, one of the BMC Methods journals. We deliberately introduced 6 domains of assessment to harmonize with the methods of Cochrane for risk of bias. So our domains of assessment are the rationale for the homeopathic intervention, the extent to which the principles of homeopathy, like treats like and so on, were adhered to explicitly in the study, that homeopathic practitioner input at some appropriate level was evident in the study concerned, that the outcome measure was relevant to the intention of the homeopathic treatment, homeopathic treatment intention, that the outcome was sensitive to change, up or down, and that the duration of the follow-up to the endpoint was relevant again in terms of what one can rightly expect of a homeopathic treatment effect that works. And our vocabulary for acceptable model validity, this is corresponding to the reliable evidence as regards risk of bias earlier. We must be free of concern of model validity in 4 specific domains of assessment: rationale, principles, outcome measure, and its sensitivity. And we allow unclarity in just one of the other 2 remaining domains. So if we satisfy those criteria, we have acceptable model validity. Now this is softened from, I presented the model validity work only in Barcelona, and some of you will remember that we had some afterwards discussion about the stringency with which we were applying the practitioner input modality. So we learnt from that conversation, and we've therefore allowed unclarity about extent of practitioner input, yet enable an acceptable model validity result. So these results, which are otherwise were then published subsequent to Barcelona, reflected that rather more appropriate, I would say, recognition that in papers, for example, 20 years ago, would not necessarily have described the extent of practitioner input. So those with acceptable model validity are number 19 in total. I just wanted to show that you don't need to recognize necessarily each individual study, but there they are for your the specifics. And then we built in those with uncertain model validity and inadequate model validity. So across all 32, the vast majority are at least uncertain, but really rather a large number, rather happily have acceptable model validity. Only 4 are inadequate. And that paper is in peer review right now, in which we're merging, and this is the final phase of this presentation. The crucial thing now is that we're merging the data from risk of bias assessment to those of model validity. And without going into extreme detail, this is just a summary as I can make it. We're attributing 4 levels of quality now that reflect those 2 attributes: high, moderate, low, and very low. It's consistent with what's called the grade approach to assessment of quality. Basically, we have either very good in both model validity and risk of bias, not quite so good in at least one attribute, poor on at least one attribute, or poor on both. And the results don't change compared with risk of bias alone, hardly at all. We still have, instead of 12 with at least uncertainty, we've now got 11. And the great thing is, the happy news, is that those 3 critical, reliable trials also had good model validity, and those are they. So the 3 studies that we like, especially, we also like in terms of model validity. So collectively, they're of high quality. So it means that the results of the meta-analysis do not change. Collectively, across all 22 studies, the odds ratio of about 1.5, and across just the 3 studies on a sensitivity analysis, about 2. So the collective summary statement: we still have the 22 RCTs with a ratio of 1.5, the 3 with about 2, So the corresponding statement from earlier, it was just matured a little bit now, and importantly, we have a statistically positive result from all 22 studies that remains robust to sensitivity analysis based on high quality evidence. Now that's something to say confidently to your peers and adversaries. So we've got data that are consistent with a small clinical treatment effect that are specifically due to the medicines prescribed in individualized homeopathic treatment. But in your sharing of thoughts on this work with your peers and colleagues, do reflect also that these important caveats exist, because of the body of the evidence at this time, as we speak, is still insufficient to have a decisive statement. So I'm presenting something that is confident but cautious. Caution is the thing. Caution is always the thing in science. The last 3 slides reflect wider inferences that I want to, and rather look forward to discussing with you all now or at lunch. The point that is important is that our results reflect a wide spectrum of medical conditions across these 22 studies that were eligible for meta-analysis. That is really important. So what we can say is that there is some evidence from clinical trials that individualized homeopathic medicines may have positive treatment effects in a spectrum of health disorders. So, by inference, we can say that there is some RCT evidence that individualized homeopathy may be effective in treating several health disorders in a given patient, from which we can say that we have a grasp of data from RCTs that are placebo-controlled and individualized homeopathy that could have impact in this whole key area of multimorbidity. So this cautious conclusion, therefore, and I use this terminology in the abstract as well, we can transcend, we can rise above and look down on the condition-based analysis that, in my personal opinion at least, can maybe drag us down. We can rise above being dragged down by a medical condition because of these cautious results from this meta-analysis. And we can therefore recognize that we can have a different view and consideration of results from meta-analysis compared with Lind, who rightly said that his data were not clearly efficacious. It didn't show that homeopathy was not clearly efficacious for any single clinical condition. And in the adverse circumstances of the Australian report with its different and unfortunate bias, their statement need not be so worried at, because we can counter that as long as we listen to. And then finally, just to repeat really and emphasize that we have research, we can take the research evidence picture away from single medical conditions and towards patients' individuality as a consequence of doing this RCT analysis. And the really critical thing is, in this age of, despite this excellent research blossoming, but because of the criticism that's louder and sharper and penetrating, we have got some influence in defending and promoting homeopathy through its most relevant evidence base, that of randomized controlled trials of individualized homeopathic treatment. Thank you very much.